Welcome everyone to today's session of the Survivorship Series led by Dr. Ting Bao. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the Survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist in our Blum Digital Resource Center, as well as the Survivorship website. For those of you watching live, if you have any questions to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website, www.dana-farber.org/resource center, or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now introduce Dr. Bao. Dr. Ting Bao is the co-director of the Zakim Center, the past president of the Society for Integrative Oncology, or SIO, and the current co-chair of the SIO Education Committee. She was a joint faculty member at the Memorial Sloan Kettering Cancer Center, Integrative Medicine and Breast Medicine Services, and the director of the Integrative Breast Oncology Program at MSK from 2014 to 2023. She is a board-certified breast medical oncologist and medical acupuncturist and integrative medicine physician. She has conducted a number of clinical trials that examine the safety, effectiveness, and underlying mechanisms of acupuncture and yoga, cancer patients' quality of life, and to address treatment and disease-related symptoms. Because of her clinical and research expertise, she is a member of National Cancer Institute, NCI, Physician Data Query, Complementary and Alternative Medicine, CAM, Educational Board. She is also a member of the Alliance for Clinical Trials in Oncology Symptom Intervention Committee, and she is a speaker and panelist for NCI and conducted workshops on oncology acupuncture and cancer CAM. Now I will pass the workshop over to Dr. Bao.
Great, thank you so much for the kind invitation and introduction. So let me get started. So today I'm going to talk about integrative medicine for a very common cancer treatment-related side effect named chemotherapy-induced peripheral neuropathy, CIPN. So this is my disclosure. And then my background is I'm a board-certified medical oncologist trained at Johns Hopkins Medical School residency fellowship, focusing on treating breast cancer patients. And then also I'm an integrative medicine physician trained at Memorial Sloan Kettering Cancer Center, where I spent 9 years from 2014 to last year. And then also I'm trained a medical acupuncturist, trained at the Helm Medical Institute, at that time affiliated with UCLA. And I'm also a physician scientist focusing on conducting integrative oncology clinical trials. And my career goal is really to integrate complementary medicine into oncology practice to improve patients' quality of life and overall survival. So let's focus on CIPN, chemo-induced peripheral neuropathy. This is one of the most common persistent treatment-related complications, and it occurs with frequently used chemo agents, which include platinum, taxanes, bortezomib. And the common symptoms include pain, tingling, numbness, sensory loss, poor dexterity, and gait disturbance. And the treatment are basically pretty limited. So the current standard of care for CIPN, basically for CIPN during chemo, is usually not very effective prevention intervention. So we dose reduce chemo or discontinue chemo. And then for persistent CIPN after chemo completion is symptom management with either pain medication such as narcotics or antidepressants and anti-epileptics. But the problem is the treatment has limited effect and potential significant side effects. So as a result, ASCO, American Society of Clinical Oncology, actually every few years come up with guideline. The most recent one came out in 2020. Basically, the recommendation is no agents are recommended for prevention of CIPN during chemo. And therefore, they have to talk about dose delay or dose reduction or stop chemo, which could potentially affect the effectiveness of chemotherapy. And then in terms of persistent CIPN, right now, the only recommended agent by ASCO is duloxetine, also called Cymbalta. It does have some evidence support its use for people with established painful CIPN, but the amount of evidence benefit is limited, which I'll talk about. Therefore, additional treatments are definitely needed. So how about integrated medicine approaches? So that we're talking about non-pharmacologic approaches, such as acupuncture, yoga, and others. So we'll spend the next 30 minutes talk about those and the evidence behind it. So what is acupuncture? Acupuncture is the traditional Chinese medicine techniques of inserting and manipulating those hair-thin needles into acupuncture points, the so-called acupoints, to reach therapeutic effects. And so what are those acupoints? Study has shown those are the points in the body that has high density of neurovascular structures and low electrical resistance. And in general, is between or at the edge of muscle groups. So there are over 360 acupuncture points. And as you can see, like each points are corresponding to certain organs or symptoms. And the most commonly used are about 60. So a typical acupuncture session involves putting patients on a comfortable bed, and the acupuncturist would talk to patients, find out the symptoms, and design the treatment protocol. And then they insert the acupuncture needles and stimulate it to the point, in major points, it would reach this 得气 sensation. It's heaviness, numbness, and tightness. Then you leave the needles in place for 20 to 30 minutes. Usually we darken the room and play some nice music. And yeah, just have patients relax. And acute condition, for example, you sleep wrong on the bed and have like neck pain, one treatment may be enough. And whereas chronic conditions usually require several sessions. We usually say at least 6 sessions. So exactly how does it work? We don't know for sure, but there has been over the past many years, so many research groups have done amazing research in this area on animals and human, and we come up with a number of series. So it's getting more clear. The most common one people mention is this neurohormonal pathway. Basically, you insert the needle, stimulate the nerves. That's why you have this dull, achy sensation often. And then that sends signal to the brain, and it activates this hypothalamus, pituitary gland, and therefore cause change in neurohormonal peptides, such as beta endorphins and enkephalin, and those are the endogenous opiate neuropeptides. And then some other studies suggest it works by manipulating neurotransmitters, such as brain-derived neurotrophic factor, which is low in patients with depression, and then can be low in patients with CIPN. So as you can see, that may be how it helps. And then another series is NeuroGate series. So basically by inserting needles causes sort of non-painful stimulation. It blocks the pain perception. Therefore, you don't feel pain much. And then other theory suggests, in animal studies especially, suggests that acupuncture works by stimulating this endogenous pain inhibitory pathway, and therefore produce this analgesic effect. And other studies say it works by decreasing inflammation through immunomodulation, by decreasing the pro-inflammatory cytokines, and increase the anti-inflammatory cytokines. And then lastly is it may works by modulating brain activities through those functional MRI studies. So as you can see, here we see this LR3 is liver 3. So that's a point in your foot between the big toe and the second toe, which we use it often. Once you insert it, different area lights up. So it's different from LI4, which is actually on your, it's large intestine 4, but it's actually not in the large intestine, it's on your hand. So you see the different area lights up with different point stimulation. In 2021, there's amazingly well-conducted trial, actually, done at Dana-Farber, published in Nature by Professor Liu's group. And basically, it suggests that there's this neuroanatomical basis for electroacupuncture to drive the vagal adrenal axis. That's a big boost for our field. It's animal study. And then, so all in all, in addition to try to figure out the mechanism of acupuncture, we also try to figure out if it's safe. So multiple studies has been done, and it shows that acupuncture is really safe, especially when performed by qualified practitioners. As you can see, the severe adverse reactions is very little, 0.05 out of 10,000 treatment. And then that include pneumothorax, but you need to put needle like around the truncal area. And often we don't do that. And then broken needle, that's in the era that needle's quality wasn't that good, but now has significantly improved. Infection, so that's before, years ago, people were reusing acupuncture needle, but now it's all disposable, so only use once. So that significantly reduce the risk of infection. And then there's some minor side effects, which include bleeding or bruising. But just think about it, like the needle, acupuncture needle is small enough, it can tunnel through the needle they put in to draw your blood. So, so the bleeding and bruising is pretty limited and resolve pretty fast. So let's go back to CIPN. What's the evidence of duloxetine and acupuncture for chemo-induced peripheral neuropathy? This is all in the setting of persistent CIPN. So as you can see, so basically, this is the data supporting using duloxetine. This blue line is a diloxing arm, and then the green line is a placebo arm. And the duloxetine arm reduced the pain by 1 point out on a 0 to 10 point scale, whereas placebo reduced the pain by 0.3. So the difference is 0.7 in a 0 to 10 point scale. Toxicity include fatigue, insomnia, and nausea. And then around the same time, our group actually published a pilot study on acupuncture to reduce Velcade-induced painful neuropathy. So it's slightly different scale. It's a 0 to 100 pain point scale, and acupuncture significantly reduced the pain by 20 points out on the 0 to 100 pain point scale. And importantly, after we stopped acupuncture at 10 weeks, the pain reduction persisted. And the main side effect is mild bruising. So encouraged by that, we got institutional funded pilot study from Memorial Sloan Kettering Cancer Center when I was there. And then the funding basically support us to do a phase 2B trial, which is compare real acupuncture with sham acupuncture with usual care. As you can see, and the treatment is 8 weeks. So real acupuncture started decreasing pain already at week 4 and more significantly at week 8. And then importantly continues at week 12, even after you stop acupuncture 4 weeks ago. And sham acupuncture decreased pain a little bit, 1 point versus 1.7 point on a 0 to 10 point scale. But then at week 12, it bounced back. And then usual care didn't change much. So yeah, based on this encouraging data, our group was very fortunate to be funded by NIH R37 grant, which is basically 5 years and can convert to 7-year grant to support a randomized phase 3 clinical trial of acupuncture for chemo-induced peripheral neuropathy treatment, our ACT trial. So I started the trial at MSK and last year decided to accept the offer at Dana-Farber and moved here. So the plan is really to do a multi-center trial. We'll continue at MSK and started at Dana-Farber. So this is the trial design, the ACT trial. We plan to enroll 250 patients, randomize them into real acupuncture, electroacupuncture versus sham acupuncture. And then the intervention is the same for 8 weeks. Then we have a long-term follow-up for up to like 24 weeks. And then our aim is really to determine the efficacy of 8-week electroacupuncture treatment on CIP and symptoms with moderate to severe CIP and pain. And also we want to evaluate the effect of real electroacupuncture versus sham acupuncture on more objective endpoint, basically on this small sensory fiber function measured by quantitative sensory testing, QST. And then lastly, we also want to evaluate if there's any predictive markers to predict response to electroacupuncture, such as like different kind of baseline QST. Yeah, so this is the main, those are the main eligibility criteria. So this is really in the patients with persistent CIP and after chemo has finished at least 3 months ago and with no evidence of disease or have stable disease. And then must have diagnosed with CIPN based on symptom history, and then must have average CIPN pain for greater or equal to 4 in the past week on a scale from 0 to 10. And so either they don't take anything or they have to be on a stable regimen. So this is a progress. We received the notice of award from NIH in December 15, 2020. We opened the trial enrollment at MSK in June 2021, and our target enrollment is 250. Right now we have 134 patients, and the goal is really to complete enrollment by April 2025. Fingers crossed. And what's next? So we really want to make sure this is a multi-center trial. So we plan to open it at Dana-Farber ASAP. Right now, we keep on pushing it back, but we're hoping to open it in March. Yeah, if we're lucky, it's like February. There are a few little sort of institutional agreement documents still pending, but hopefully we'll get this started soon. And then in addition, we want to further explore the mechanism of CIPN and how acupuncture may help reduce the CIPN pain. So that goes to this R37. So basically this year, we're going to apply for, send another application to NIH saying we want to potentially do further study on the mechanism part. We want to look at the inflammatory markers, brain-derived neurotrophic factors, and potentially collaborate with MGH to do functional MRI. So stay tuned. And then, so that's acupuncture. How about yoga? So we noticed that CIPN significantly increased risk of fall. So our observational study basically suggested that when the degree of CIPN increased, their rate of falls significantly increased as well. And then that's when yoga start coming to our mind because especially Hatha yoga is meditative movement therapy. And the study has shown it's really strengthen the body, increase flexibility, and mind-body awareness. And evidence really suggests yoga helps improve anxiety, fatigue, and functional outcomes, potentially can decrease risk of fall. And most cancer centers already offer yoga therapy. So if it's proven to be helpful, we can readily start implement it. So our question really is, can Hatha yoga help reduce CIPN symptoms and reduce risk of fall? And then the possible mechanisms involves potentially yoga helps increase blood flow and oxygen supply, therefore cause this neuroprotective effect. It may help decrease inflammation, may help decrease anxiety and depression, because we also know that anxiety, depression correlate with pain. And then it may help, some pilot studies suggest it helps to increase BDNF, brain-derived neurotrophic factor. So got an institutional pilot grant from MSK and conducted this pilot randomized phase 2B trial on yoga for CIPN and fall risk. So this is a single center, 2-arm pilot study, only 40 patients, 20 in each arm, to really see if yoga can help reduce CIPN symptoms. And then we want to use this trial, the results to basically get prelim data on the effect of yoga compared to usual care in reducing CIPN symptoms, and therefore to help design a fully powered randomized controlled trial. And this is a study schema, 40 patients randomized to yoga treatment arm versus usual care. And it's 8 weeks treatment. And then we also monitor them for 4 weeks after they finish the active yoga treatment, although they still do home practice. And then compared to usual care group, and then to incentivize the patient, we offer 8 weeks yoga treatment. So that's the details of intervention. Yoga group, they get 1 hour instructor-led yoga class twice per week for 8 weeks. And then they also do this home-based yoga practice. We send them the route, they do it. And then weightless control. They wait for 12 weeks, and then they can do yoga. So this is the main result. As you can see, even though the curve didn't separate completely, but there's clear trend. So the CIPN pain also decreased in the yoga arm, and to the point is like at week 12, it's about 2 points pain reduction. That's significant. And then compared to the weightless control arm, it's possibly because the sample size is small, only 20 patients in each arm, the 2 curves didn't separate. So further study definitely needs to be done. And then we also look at other endpoints such as FACT, GOG, and TX. So that's a questionnaire of 11 questions, ask our patients to assess their CIPN symptoms and also function. Their functions such as walking, buttoning buttons, or able to tell the shape of the small subject in their hands. So they separate. So basically, especially at week 12, as you can see, the yoga arm, their function, the higher score, the better their function is. So it's significantly better than the usual care arm. Suggests yoga really help improve their functions affected by CIPN. And then the functional reach test. So this is a test that basically we ask patients to close their eyes and then like far reach as much as possible before they feel like they're going to fall. Then we measure the distance. And the higher the functional reach test number is, the lower the risk of fall is, separate right away. So the yoga group seems to significantly improve functional reach test and side effects. So all grade 1, meaning basically just mild and self-resolved and doesn't need medical attention. In the yoga arm, it's like myalgia, muscle pain, 3, and leg cramp, 1, and then weightless control, none. So minimum side effects. So very promising data. As a result, we actually 3 months after we submitted the ACT trial proposal to NIH, we submitted a YCT yoga CIPN treatment proposal to NIH. We got funded as well 3 months later. And so this basically is the same thing. We started at MSK and now we want to do multi-center, Dana-Farber and MSK, and it's supported by NIH R01. And this one, per reviewer's request, they want us to add an education arm. So we plan to enroll 268 patients in 2:1 ratio, yoga arm, education arm, and usual care. And it's like for 8 weeks and then follow with long-term follow-up for a total of 24 weeks. And then our goal is also to determine the efficacy of 8-week yoga treatment on CIPN pain. And mainly because the grant mechanism is supporting pain research. And also the most promising data is in CIPN pain. And then secondary endpoint is really to find out if yoga can help improve balance and reduce risk of fall. And yeah, and if it's fact on quality of life. And lastly, we also want to explore the effect of yoga on improving sensory function, the small fiber sensory function measured by quantitative sensory testing. So progress, we received a notice award in March 2021. And then this one took a little longer because of COVID. We finally opened enrollment in November 2021, and with the target enrollment is 268 patients. We so far enrolled 104 patients. And because of COVID, especially the Omicron, this is, as you can see, that's when the Omicron occurred. We really switched all yoga instruction from in-person to virtual, and then we opened it nationwide. And then the goal is to complete enrollment by December 2025. So what's next? Open it at Dana-Farber ASAP, hopefully this month or next month. And we also plan to potentially restart in-person yoga session at Dana-Farber because our ZACM Center has resumed the in-person yoga session. So that's an option, whereas MSK has not resumed in-person yoga session. We also potentially want to explore further mechanism of CIPN and how yoga may reduce CIPN symptoms if it turned out to be positive. So, and then the last trial I want to mention is about the CIPN prevention. Can acupuncture help prevent the worsening of CIPN? And this is a trial we started at MSK, right now stayed at MSK. I should mention that at ZACM Center, Dana-Farber, we also have a similar trial going on. It's called PACT trial, which I'm happy to send you information. And this one is based on our phase 2 single arm trial on acupuncture to reduce CIPN symptoms during neoadjuvant, meaning before surgery, or adjuvant, meaning after surgery, weekly paclitaxel chemo. So in this trial we published in 2018, we showed that basically patients' CIPN definitely getting worse with weekly paclitaxel. And then, but if they reach grade 2 CIPN, we intervene with acupuncture. It seems like patients, even though despite continuing chemo, their CIPN symptoms plateaued. And then, so that's why the ATP trial is ongoing at MSK and PACT trial is ongoing here at Dana-Farber. The plan is to get, at MSK, we're comparing real acupuncture with sham acupuncture when patients receive develop grade 1 CIPN. Whereas at Dana-Farber, it's basically upfront, everyone getting weekly paclitaxel, and then give them real acupuncture versus usual care. So study is still ongoing. And the goal is really to find out if acupuncture can help prevent the chemo-induced peripheral neuropathy. And so far, at MSK, we enrolled 42 patients out of 80. At Dana-Farber, I think the goal is 100. We so far enrolled 54. So integrated medicine, CIPN research future. What about the mechanism? We really want to figure out the mechanism. And what about other modalities? There's so many other non-pharmacologic approach integrated medicine modalities, such as massage, Tai Chi, exercise. And what about different settings? So how about metastatic setting? How about more studies during chemo? So this is our tree, CIPN research, integrated medicine CIPN research tree. So that's right now we have acupuncture yoga phase 3 trial already going. We're thinking about going into pilot study, Tai Chi, massage, exercise. I think there is one exercise study already ongoing at Dana-Farber. And then we want to, right now we have prevention, acupuncture during chemo in neoadjuvant or adjuvant chemo setting. We're hoping to go into massage in the metastatic setting. And then in addition to patient-reported outcome, we're expert in quantitative sensory testing and functional assessment. And how about other endpoints? And also we really want to increase outreach to lower income patients. And finally, I just want to thank all these people, funding organism and organizations, mentors, co-investigators, and research team. It really, and especially thank to our patients. It takes a village to get research done. So that's me doing acupuncture. So I'm happy to answer any questions.
Thank you so much, Dr. Bao. That was a great presentation. Very, very informative. We do have a couple questions that came through. I'm happy to read them
Sure.
now in no particular order. So the first question I see is, how is CIPN diagnosed?
So it's a clinical diagnosis and also can be a sort of physician diagnosis. So basically when patient come in basically saying I'm totally fine, especially some are very simple, like easier to diagnose than others. So sometimes patient come in saying I'm totally fine before chemo, and now after I started this chemo, especially the different types of chemo I just mentioned, then I started having tingling, numbness in my fingers and toes and started having pain. That's in a way is CIPN, chemo-induced peripheral neuropathy, because you know clearly. It's a little hard to diagnose if they have pre-existing neuropathy. However, if it's getting significantly worse during chemo, then that's, you know, you kind just clinical diagnosis, you have CIPN. And then to make a definitive diagnosis, sometimes we refer the patients to neurologist, basically saying, can you evaluate the patients and then make a clinical diagnosis? Then they sometimes can do nerve conduction study, etc. But our research basically show that even if the nerve conduction study is completely normal, if patients have tingling numbness, suggesting they do have neuropathy. So in a way, I don't necessarily think you have to see a neurologist to be diagnosed with CIPN. With the classic history, you do have those diagnoses. Yeah, and then sometimes they do neurologic tests and stuff just to kind of further confirm it. Yeah.
Thank you. The next question is, what is the difference between peripheral versus radicular neuropathy? Is acupuncture effective?
Difference between is that peripheral versus central? I'm not quite sure the second term.
Radicular neuropathy.
Radicular. Okay, got you. Maybe I'll just start with explaining like peripheral means like sort of the, you know, we have basically we're a body full of wires. So all these nerves go everywhere. So peripheral nerve means all the nerves sort of in your extremity. Yeah. Like outside the main like brain and spine. So central neuropathy suggests like neuropathies like in the brain, like yeah, I sometimes wonder the chemo brain actually may be a type of central neuropathy. And then yeah, most people think that way anyway. And then so peripheral neuropathy is more like, you know, the extremity symptoms. And radicular neuropathy is different because it's more like, for example, you have herniated disc, and then it's like, and then that compressed the nerve root. And then you have this shooting pain from the lower back to the lower back to the lower leg and stuff. So that's radicular neuropathy. And the treatment is different. I would say acupuncture may be helpful, like sciatica acupuncture has been shown to be helpful, but like in a way, you probably need to address the root problem. Yeah, so sometimes people do need to do surgery to take away that like bulging disc or something. That's maybe more definitive way to treat. Yeah.
Thank you. The next question is, how do you plan to identify and recruit Dana-Farber patients for the ACT study?
Yeah, so we're actively, honestly, we've been ready for a long time. We really want to get this started as soon as possible. So we have been talking to I forgot the name, but anyway, a organization, so they keep track of all these people with basically who has finished chemo and this type of neurotoxic chemo. We have a long list of that. And then so we plan to, once this trial is open, before that we cannot, but then we plan to send lots of letters or portal message, gateway message to those potential eligible patients and far reach. And then, you know, that's I would say that's the most successful way from MSK. So patient then call back. And then second way is I start doing this presentation at different disease group and then make physician aware and then make nurses APP aware. So then they can refer eligible patients to us. So those, and then in addition, there's flyers and everything. But I think, yeah, physician, like letters, professional referrals are the most common ones. Yeah.
Next question is, can CIPN appear years after chemo?
That's a great question. To be honest, I don't think it's that often. I think I would never say never. So I think it can, but it's unusual. Often is patients start developing CIPN during chemo, and then yeah, usually the typical course is after chemo, the symptoms get better. But with that being said, there is some phenomena called coasting effect, meaning even after chemo, there's neuropathy, CIPN got worse for a few months. So that's called coasting effect. So don't be alarmed by that. That's still part of CIPN. And then gradually it should get better. But that's why we're here. We're trying to develop treatment for that. Yeah.
Awesome. These are great questions. The next
Totally.
question is, what is sham acupuncture?
So it's I cannot really go into very detail because I don't want to like kind of disclose the study design at this point. There are different types of sham acupuncture. Basically, it's not like sham, like different points. You put it in different area. That's one type of sham. And then different type of insertion. You put it deep or low, or yeah, that's different. Yeah. So yeah, that's as far as I can say. Yeah.
Thank you. The next question is, can most acupuncturists handle acupuncture for CIPN?
That's a great question. I would say depends. If they're very active and very up to date with literature, they should. But with that being said, I think right now we don't have a set protocol. The hope is, if we find out that this protocol is really effective, then the next one is implementation. So basically we do research, then we disseminate research, we present the research result. Then third step is implementation. We have workshop and all this. We train acupuncturists to do that. That's actually one of my vision for the Zicam Center. To have more training session for the community acupuncturists so that they know like how to handle those like very common symptoms.
Awesome. And then the last question that I see, is there any hope for relieving numbness?
Maybe not 100. There's always hope. I always believe there's hope. Relieving definitely completely go away is a little challenging, but relieving is definitely helpful. The reason why we didn't list numbness as the primary endpoint of this trial, not only because the founding agent focused on pain, but also because when we compare real and sham acupuncture, and the reduction of numbness is the same. Both group has 2 point out on the 0 to 10 point scale of reduction of numbness. So they got better. Yeah.
Great. Thank you so much. I don't see any more questions at this time. Dr. Bao, I just want to thank you again for taking the time to present for us. It was really wonderful. I learned a lot. As I mentioned earlier, this session was recorded and it will be posted on our Blum YouTube playlist, our Blum Digital Resource Center, and the Survivorship website.
Thank you so much.